Right, so just to start with, there's a couple of housekeeping bits, and this is the agenda. So I'm going to start with some housekeeping bits, and then we've got Dr. James Turbo who's going to talk through the pathway and some introductions and explaining what it is, how it works, and why we're doing it. And I'm going to quickly just go through a bit of stuff on how we've rolled it out, what we've done, and what resources are available for yourselves as well. And then we've got Paul McGettigan from, not Kate Allen, but Paul McGettigan from the Business Service Authority. He's going to just talk about their programme, their specific programme, and what they're doing as well. And then we've hopefully left quite a bit of time for some Q&A at the end, just so that we can support you if you have any questions, etc. So far we've got 21 people that have signed into this from all over the country, which is really nice to see, and from a range of HSNs. So again, there'll be people on there that will have similar issues to yourself, so please do ask questions, etc. So, making sure that you're all dialed in and that you can all hear this. I hope you can. If you can't, there's some instructions on where to look to dial in on the screen now. So if you go to communicate, you can click our call in, and that will provide you with dial-in details on how to get in. So hopefully you can all hear us now. And if you do have any questions throughout, please put them in the chat box and send them to all participants, sorry, not all panelists. And that way everybody can see what's being asked, so that we don't duplicate questions, or you can see where the conversation's going, and we can basically see what support's needed, what questions we have, and other people might be able to answer some of the questions. So it's there as a general chat box for us all to kind of follow around Faecal Calprotectin. Just checking, is James logged in yet? No. I can promote Paul. So I'll just try and go through a little bit of James's stuff until James gets on, but yeah, I could do. I have to go through it, but yeah. So while we're waiting for James, I'll do my bit, if that makes sense, and then we'll have to go back. So I'm sorry you're going to see all of the slides, but we'll just have to skip back to James when he's available. So let me just skip through all of these. Right. So once we got the idea from James, we decided that the best thing to do was to develop a large portfolio of resources which would help the CCGs and trusts to be able to easily pick up this project and then implement in their own areas, to try and reduce the amount of effort that they would kind of see. And this way we've got quite a lot of buy-in from those CCGs and trusts, because essentially a lot of the hard work's been done for them. So we worked with York CCG, York Hospital, with their labs and their gastroenterologists, to develop these, as well as some GPs from the CCG as well. So we've produced a series of business cases for CCGs and for trusts, in case they need them specifically for those areas where Faecal Calprotectin isn't already being used. So they need to go through the business case scenario to get them through and approved. So we have templates on System 1 and EMIS already, so they're for GPs to pick up, drop in, and then whenever they see one of these patients, they can implement and follow the pathway, and it tells them exactly what they need to do, where they need to go, and what the results mean, and what they need to do following those. We've got quite a bit of training and comms work done, so we've got some initial comms to go out in CCG's newsletters, and there's a YouTube video which has James talking very eloquently about the pathway. So I can happily share that video with you outside of this, as it's quite a good refresher as well for GPs when they don't see a lot of these patients regularly, that this actually helps them understand what we're trying to achieve. So we also have a patient leaflet and a GP leaflet. So these are basically giving a bit more information on what fecal calprotectin is, what the pathway is, why it works, what they need to do, etc., and what's the options if you don't want to do fecal calprotectin, specifically for the patient. So if they don't do this test, then they're more likely than to have to go for invasive colonoscopy, etc., for support of diagnosis. And we've been working with some of the trusts who have direct colonoscopy stuff about how we manage those pathways and making sure that compliance is kind of adhered to within those areas where they have straight to test there and straight to they don't get, you know, they have a different referral pathway. So we've been working with them to make sure that they still follow the pathway quite well. So all of these resources are now on the NHS Networks page. The link's there, but I will share outside of this. So that has all of the resources that we have. So that also includes some of the case studies that the Business Services Authority have developed that we can also use as examples to help promote this and give those real-world examples to CCGs and trusts. And then we have also developed, well, I'm developing a Cahoots page, so the HSN Network have set up some Cahoots pages. Once I've been trained on how to use it, I will be putting things up there and I will be sending you all the links, but that's still in development, and as soon as it's up and running, I'll make sure it definitely goes around to everybody. And then, as well as those, myself and James, with our lovely pictures at the side, I'm more than happy to come and talk to any of your CCGs or in your STP meetings or wherever we're needed, if we're needed. The offer is there to support those early conversations if they are needed. Because obviously we've been through it before, and we kind of have heard some of the questions raised before and know how to answer them, etc. And James is so passionate about this that it really comes through in the discussions. Is James on yet? No.
She's just having trouble. You do the refresh.
Huh? If you can't talk to all participants, you can just chat to all panelists, and that'll and the questions will come to us. So that will be fine as well. We can always help your discussions through that when we get to the Q&A bit. So while James is still not on, Paul, I don't know whether if it's possible for you to do your bit next. I hope that's okay. Oh, I forgot to say as well, there is a consensus paper, but I'll come back to that in a second. Right, so Paul, you should be the presenter now. Are you dialed in? No, Paul, we can't hear you. Have you dialed in? Or are you off mute? Right. And so we'll just give it a couple of seconds. Just Paul's having a couple of connection issues, and then we'll be back on it. I'm really sorry for this slightly rocky presentation, but we'll get straight on it as fast as we can. Hang on a second.
Hello?
Hello.
Hello, can you hear me?
Yes.
Oh, my apologies. I thought using the laptop connection was connecting straight into the call, but I was wrong. My apologies.
Yes. Do you want to just go through your slides then, Paul?
Yeah, of course. Sorry about that. So, I've got control of the screen now, haven't I? So.
You do, yeah.
So, oh, we're missing a page. Okay, so welcome everybody. Thank you very much for having us this afternoon. My name is Paul McGettigan. I'm the Innovation Lead on the Pacific team as part of the NHS Business Services Authority. We also have kind of joined in and involved in the questions my colleague Francis Walker, who's our Change and Transition Lead. So today I'm going to talk a little bit about Pacific and our role in developing a national consensus for calprotectin testing and the subsequent spread and adoption thereafter. And when we talk to people across the system, we often have to start with who are the BSA. Sorry, this screen isn't going. I can just do it like this. These are supposed to come in gradually, but that's fine. We can wait with it. So the BSA, we're a special health authority and a national arm's length body of the Department of Health. And we deliver a whole host of different services for the NHS with a kind of an annual financial flow through of about 35 billion. So to put that into context, it's about a third of NHS spend comes through the NHS BSA at one point or another. Traditionally, we've been quite a quiet running organisation. We process big volume activities really accurately and efficiently. The vast bulk of that 35 billion is through the NHS pension scheme, where we process around £20 billion worth of payments. NHS prescription services process around £10 billion worth of prescription items, and NHS dental services process around £2 billion of payments. On the right-hand side there, you've got a number of other areas of the business, all traditionally kind of high-volume transactional services. And that leaves us with a lot of information and data on our data systems. And at the top of that list on the right-hand side, you'll see information services. And they've invested in some real cutting-edge Oracle technology that allows us to get all of that data and information across our multiple services and look at them in new ways, new exciting ways to develop opportunities for the system. So with the 35 billion and the capability to look at information in a different way, Department of Health and Social Care set the BSA an objective to try and save £1 billion in the system, and that's where the Pacific programme was born. For the Pacific team, we consider ourselves as national innovation and delivery partners. We're a team of about 20 business change specialists with a keen eye for benefits management, but we do business analysis, programme management, facilitation, a whole host of different kind of business-related skills, services. So to date, we've saved over £865 million, and that's annual recurring savings to the NHS, and obviously without compromising patient care. But it's not all about the money, and we've got this objective now to try and help the NHS deliver sustainability for the NHS, and we are increasingly looking at opportunities that increase the quality of patient care as well as improving patient health and well-being. And we're really lucky that we're funded by the NHS BSA and by NHS England, so we can offer our services to our partners across the system, to collaborate with partners across the system free of charge, obviously within reason, because we are a limited resource, so we do have to prioritise. Next. So again, this was going to feed in through the presentation, but I'll talk a little bit about how, I guess, Pacific's involvement in calprotectin testing, from the kind of discovery through to the development of the national consensus, through to spread and adoption and benefits monitoring thereafter. So I'll start with discovery. So back in 2016, we carried out a national primary care diagnostic survey, and it was identified that, obviously, despite being recommended by NICE, there was still relatively low uptake. So we gathered research and evidence from across the system to understand that landscape a bit better, and we worked specifically with 2 CCGs in the Staffordshire area who had been running a year-long pilot on calprotectin testing, and we used their information to create a national case for change. So this takes us to the national consensus. We used that data and that national case of change to develop a proposal for NHS England's Chief Scientific Office. It was felt that it was a win-win-win for GPs, for CCGs and for patients. And they then decided to create a national working group to gather that national view, pulling various people. Prior to that group commencing, we identified and invited a number of kind of specialists from across the country, and at that point I think James Turville and Vicky were invited from Yorkshire and Humber, but also other Dr. Andy Poulis from Oxford, I think he's based in Oxford, or St George's. And then we also invited a number of primary care GPs, HSNs from Oxford and from Yorkshire and universities. So it was a real multidisciplinary group, and that group lasted quite a few months talking about various pathways, and we're now, I guess, from a Pacific point of view in that group, we help facilitate that group, but we try to give an angle of the benefits, of the financial benefits. So when we were discussing changes and decisions that were being made, we were trying to bring that financial angle into those conversations. So the paper is now published. It's available on Primary Care Commission website. It's been endorsed by NICE and the British Society of Gastroenterologists, and it's also been supported by Crohn's and Colitis UK, who are the leading IBD charity. So that's all fantastic. So the next step, based on the information that we learned through the discovery phase and going through that group, we've developed a number of case studies. So from a commissioning viewpoint and the challenges and barriers you may overcome, but also we've done a case study on how Yorkshire and Humber have rolled out the calprotectin testing across their areas, and that's some really useful information in there. I think that's available on the Yorkshire and Humber website, and I think we've got it on our website as well. Over the past year, we've presented at various events and forums, from kind of national health shows to actually your very own HSN Commercial Directors Forum back in March 17. We're now in the process of leading comms on behalf of NHS England, and that will include national press releases and social media campaigns. It'll include bulletins and newsletters across all CCGs and trusts. And again, we'll have presence at all the big national events and some of the local events, particularly in the North East in the coming year. Which moves us on kind of lastly around benefits. So we've identified some key data sets that I think we'll be able to use to monitor on a national basis the impact of doing calprotectin testing. We've worked with NHS Right Care to develop that, and we're now in the process of obtaining that reporting through NHS Digital. We've also developed a national model and guidance for HSNs and CCGs on how to monitor that information and learn how to, I guess, assess waiting lists and all of that criteria, and that's almost complete. And separately, we've been progressing conversations with Mike Hannay and his team as part of the central HSN network, and how we can work more closely, because we felt it was apparent. We've seen the metrics that have been asked of HSNs to feed centrally into the HSN network, but actually I think some of those metrics we will be able to get through our national reporting through NHS Digital. So again, if we can work a bit more closely with that HSN network, hopefully we'll be able to alleviate some of that kind of data burden that's being presented out there to the system. So we do want to work more closely, specifically on the gathering and the consolidation and the reporting of those metrics. So I was given a 5-minute brief, probably went a minute or two over, and that's where we're at. So if there's any other questions, I'd be more than happy to take them now, or obviously we could collate them at the end and pick them up offline. Is that okay, Vicky?
Yes, thank you. I think just for time, if we just move all the questions towards the end, but of course, if anybody does have any questions and they don't want to forget them, please put them in the chat box and we can pick them up once at the end, and your question will still be there. So James has now fortunately been able to join us, so I'm just going to move us back to the beginning and James's presentation so that he can introduce the program a bit better. Now you know about what we've got, we'll understand, we can explain to you why we're doing this and where we've got to. Right. Right, so James, you should be able to go.
Okay. Thank you, Vicky. And Paul, nice to hear from you. And thank you, Paul, for calling this a win-win-win. I think you're right, but thank you. And may I genuinely apologize for messing you all around. I couldn't avoid it. I do apologize. So if you're content, what I'm just going to do is talk to you very clinically, if I may, about this problem and about how we think we found a solution and why we've come to it. And I just hope that that provides you with a context which will be of use to you. And of course, this all turns on some very sensible but inadequately research-based guidance that was produced in 2013 by NICE, which supports the use of this biomarker, which is very sensitive at detecting inflammation in the gut, and so has the potential to distinguish a relatively uncommon problem, but one that's difficult to diagnose otherwise and important to treat, because if we don't treat it, complications arise and costs are incurred. And this biomarker, Faecal Calprotectin, was hoped designed to be able to distinguish those few patients with that condition from the many out there with functional disorders, and we call that generally the irritable bowel syndrome. This affects 30% of the population, and the symptoms are extremely difficult to be able to tell the one from the other. And so historically what has happened is that large numbers of patients have been referred unnecessarily because they've got IBS, but primary care is worried about them. But the flip side has also applied, and many people who should have been referred have not been because the GP didn't see that these patients had inflammatory bowel disease, that's Crohn's disease or colitis, and so everyone was losing out. Okay, next slide, please, Vicky. Thank you. Am I in a position to change the slides?
Yes, you are, James. Use those arrows at the top. Next.
Let me see if I. Lovely. So calprotectin had already been used in secondary care for disease monitoring. So we in gastroenterology in secondary care had some experience in using it. But the IBS-IBD guidance, that's the nice guidance we're talking about, was for primary care. And this was a new departure. And we had worked out pretty early on, even in a selected cohort, that is patients referred into secondary care, that fecal calprotectin was very sensitive. So even in a selected population, it has a negative predictive value of 96%. And in primary care, probably that rises to 99%. It does miss some disease, and so from the outset we were aware that we couldn't use calprotectin as a binary black and white test. It had to be placed in the context of some clinical judgment. But from the outset, we knew it to be very sensitive. And indeed, we knew it to be much better than what GPs were using up until that point, which is a whole body marker of inflammation rather than inflammation within the gut, and that's what we call the CRP. So on this chart, you could see that on the right-hand side, you could have very high levels of calprotectin pointed towards really active disease, and only at that stage would the CRP be consistently elevated. But in an intermediate zone, that is in the middle of the chart, where the sort of disease we're wanting to find in that context, the CRP is missing the disease. And on the left-hand side of the graph, you see that the CRP generates lots of false positives. So we knew from the outset that fecal calprotectin was great because it's high sensitivity, and in some studies, the sensitivity approaches 100%. And it was because of this sort of data that a health economic report was issued, and which proposed that if fecal calprotectin was rolled out in primary care, it would save a lot of money, £13,000 per 1,000 patients tested. Now, the problem isn't, however, the sensitivity, it's the specificity. And the original data that had informed this paper was based on a selected group of patients, and so the specificity was nearer 90%. But applied in primary care, the specificity is little better than 50%. And when that's applied to a condition that's uncommon, you're left with a very poor positive predictive value, and that means that you generate lots of false positive results. Lots of patients have a falsely raised fecal calprotectin, and if you roll out NICE guidance without reference to that, you end up investigating more patients and increasing your costs rather than the savings that are proposed here. And that has been our experience. And we have calculated that calprotectin used unselectively is costing $180,000 in primary care to the CCGs, to secondary care, per 1,000 patients tested. So this, getting it right is fantastic. Getting it wrong is a disaster. So getting it right isn't about handling the sensitivity of calprotectin. That's easy. Getting it right is figuring out what to do with those with a raised test, and this is exercised just a good deal. And the challenge here is because many patients with an irritable bowel syndrome will have a raised test. 30% of patients will have a raised test, up to 160. That's 3 times the standard cutoff. Yet we know also that patients with inflammatory bowel disease, Crohn's and colitis, a small number will come in with a calprotectin less than 200. That is in this zone between 100 and 200. And we also learned very quickly that once a test was positive, doctors tended to over-investigate, and hence the costs. So for many, the initial experience with fecal calprotectin was very negative. And this is why you got publications from my colleagues in Sheffield, who found that calprotectin wasn't an effective tool. And you found models of care like the one here on the right, introduced by my colleagues in Leeds, which was so complicated that the GPs weren't compliant with it, so that we could never demonstrate whether it was effective or not. So our response to this was to look at how we could use fecal calprotectin in 2 ways. We'd already looked at it in terms of diagnosing IBS, that is its sensitivity, and we worked out that it was very sensitive. But we then looked at our cohort of patients with inflammatory bowel disease, and we looked at all of them depending on how active their disease was, that is, how active their Crohn's or colitis was, and we plotted that disease activity according to their fecal calprotectin value. I'll just come back to this slide because I got ahead of myself. And this is the chart that demonstrates that we found that that quiescent Crohn's disease sat at around 100 micrograms per gram. That is twice the standard cutoff. But that almost all of the active Crohn's disease came in around above 250, which is about at this line. So we felt that we had two cutoffs in mind, one below which we could be very confident the patient had IBS, and another cutoff where we could be very confident that the bulk of the IBD would be picked up, and then an intermediate cutoff where there was some uncertainty and we needed clinical judgment. I'll just go back to this slide, and this just exemplifies the challenge nationally that resulted from the not knowing how to use fecal calprotectin, which we've seen already. And each of these lines is a different hospital's guidance for the use of fecal calprotectin. And this is a document produced by Birmingham, which runs the NECWAS unit. That's the Quality Assurance Unit. And it's got 4 pages of this sort of document, with each line being a different hospital. So this is 2017, you can just see at the top. So come the end of last year, there were dozens and dozens of different guidelines, different local guidances for using fecal calprotectin because of the mess we got ourselves in. So that's the background. And upon the sensitivity data and the IBD data, we generated this pathway, which we've been working on through Yorkshire and Humber AHSN to roll out regionally, locally first, where we piloted it, and then we validated it, and then we ran it out regionally and have validated that implementation, and then we're seeking to run out nationally. And this is the pathway which forms the backbone of the consensus document that Paul was referring to. And this pathway is safe and intuitive, liked by primary care, makes sense to practitioners who use the pathway, allows flexibility, is remembered, is embedded within patient management systems, and is working. And it's this pathway in its simplest form that I'm very keen to roll out, or for us to roll out and embed as the national framework. And what it does is does 2 things. As Paul said, it's a win-win. I don't quite know where the third win is, but the first win is that it allows those who can be managed within primary care to be managed within primary care confidently. Local guidance can be developed as the local practices like for patients with IBS to be treated and supported as local resource permits. But it identifies those with IBD, Crohn's and colitis, and it pulls these patients through so that they're diagnosed quickly, quicker than ever before, and so the risk of complications falls. And what we're doing on top of this is achieving this balance cost effectively. Perhaps that's the third win. So money is being used wisely because it's being directed at the right patients. So we rolled out this pathway, and the rollout has been extremely positive. From the outset, what we found as far as the number of patients with different fecal calprotectin cutoffs and therefore different approaches to care matched our projections from the pilot. The pathway of care is effectively traffic lighted. You can't see it so much in this algorithm, but there's a green traffic light, which is the low-risk pathway, and then there's a red traffic light, which is the urgent pathway, and then there's an amber traffic light down the middle, where there's a routine referral and a gastroenterology consultation, rather than effectively a fast-track colonoscopy, which is the red light. And this is paralleled by this pie chart. So 85% of patients now, whereas beforehand it was 55% of patients, are treated as though they have IBS, and indeed almost all of them do. 10% have a high-risk fecal calprotectin, and they're fast-tracked through or urgently seen, and then 5% have an intermediate amber risk, and they're seen routinely. And we've evaluated this pathway now. We've got 6-month outcomes on our first 1,000 patients, and we've published this in Frontline Gastroenterology last week, actually. And we found an excellent compliance within primary care. We found a sensitivity that was holding up, giving a 99% negative predictive value. And that's exactly the same as using the original cutoff of 50 rather than this split cutoff of 100 and 250. And our specificity has improved from 59%, to 92%, so that we've now got a justifiable positive predictive value of 50%. And indeed, that PPV improves in the population greater than a fecal calprotectin greater than 250. So we can justify spending money on rushing these patients through and investigating them. And WHEC, our collaborators who have performed a health economic evaluation on these first 1,000 patients. Now, this evaluation is based on comparator data. We don't have a true control. This is important to be aware of, and this is why the BSCA's real-time work is so important. But we have 2 comparators, and all of the data is lining up pretty well the same way. The first comparator is on published data where fecal calprotectin wasn't available at all. This is the first table you're seeing. So the intervention is our pathway, and this is compared with cases where calprotectin is not available. And we're achieving 2 important things. We're detecting more patients with IBD than historically. And we're doing that. In doing that, we're using 170 per 1,000 colonoscopies fewer. 170 colonoscopies per 1,000 patients tested fewer. And this gives us a net saving of over £100,000. If we compare our intervention with calprotectin as it was being used in the feral state, if you take my meaning, that is with the standard cutoff and using just a single test, I should say that the pathway asks that we repeat the test if it's raised greater than 100, and this is extremely important. I should have mentioned that, forgive me. This means that 50% of patients with a initially raised test normalize, and this brings them through from the amber or red into the green. So those 2 intervention differences have meant that we're saving, by this model, over 150,000 per 1,000 patients tested. Of course, we will actually diagnose one fewer patients with IBD because the cutoff is marginally less sensitive, but this isn't significant. But we save 280 plus colonoscopies. And this resource, from my point of view as a gastroenterologist, can then be redirected at looking for bowel cancer effectively. So we're shifting the care from low-risk IBS patients who are just being placed at risk into detecting something that we need to be getting better at in the UK. And what WHEC have also done, which is particularly important is that they performed a sensitivity analysis that underpins the validity of these findings. So they have shifted the prevalence of IBD in a modelling from what we found it to be, which was around 5%, to between 0 and 20%. And they found a cost saving from our pathway across all of those outcomes, of course, unless there's 0 IBD detected. And then they've looked at GP compliance, which is extremely important. This is a GP-delivered service, GP-directed. This is the market that we're aiming for. And as soon as the calprotectin starts to be used, as soon as 1% of GPs start to use it, we're getting safety, we're getting cost-saving benefits and health benefits in terms of detecting IBD. And lastly, we can move the sensitivity and specificity around a fair amount and still get a health benefit over what is currently being done. So we can be confident that this is robust data. Full stop. So this is all of what I've said now is just the clinical take on the development of and the science, what science we have around trying to offer a pathway of care. But the big challenge is in getting it out there, hooking people. I do apologise. I thought I'd turn that. Hooking CCGs, hooking primary care, hooking secondary care, and selling and getting them won over, and then implementing this at scale across CCGs. And this is what the challenge for us is next, and this is what I'm really hopeful that the AHSNs will be able to action. We know how to do it. We've done it really successfully in York and then North Yorkshire and then beyond, but we want to do it quickly and powerfully, and it's of course we need to recognise that need for scaling it up. I think that's, Vicky, I think that's all I want to say. There's this additional slide.
Yes, James, that was my slide. I've already presented.
Lovely. So I think I've gone on enough, haven't I? Thanks so much for giving me this opportunity to talk to you. Again, I do apologise.
So we've got about 10 minutes left on this WebEx. So I think this would be a good opportunity for those questions. If anybody has questions, please pop them into the chat box, and then we can help answer any of them, hopefully. So some of the questions that have come through already. One about, is there a one-page summary document available that all AHSNs can use to hook CCG acute sector that lists tangible benefits? So I think, Paul, correct me if I'm wrong, but I think the case studies that you've produced at the BSA, I think they are really clear and provide those benefits.
Yeah, that's right. And maybe not one page. We do have a one-page summary which is going to the events this year, so I'm more than happy to share that. That's just been signed off. But we've got, like I said, the AHSN perspective case study as well as the commissioner. But yeah, two sides with a lot of kind of information of things that's gone on and barriers that you might encounter and how you might be able to get over those. So again, I think they'll be linked into that NHS Networks page, but also on our NHS BSA Pacific website as well. They'll all be available on there.
Well, thank you very much. So another question that's come in is about what data would CCGs adopting this innovation need to report on? Would it be quarterly, or is there a template to report on? So I think this is something that we are still looking into as the best way to kind of collect this data. I think, is it Imperial that's
Yes, I think we've got some challenges around what data to collect when this goes into a CCG, because as James alludes to in his talk, we're creating extra colonoscopy capacity that's just soaked up by the cancer screening program. So you're not going to see a reduction in the number of colonoscopies or indeed the number of people referred to colonoscopy. So I think what we're trying to do some work on at the moment is to really dig into the coding of the diagnostics around this, and the BSA are doing some work around this as well, to really look at the ratio of patients being referred in for colonoscopy for suspected IBS, IBD, and the number of patients with IBD who are detected, and that ratio should come up from about 1 in 20 to about 1 in 4, 1 in 5. And I think it is a difficult ask, and I don't think we've got a cut and dried answer at the minute. Paul, you may want to add something, but I think what we're very confident is if we can get the CCGs to switch to the pathway and the GPs to commit to it, we have enough evidence in place already to be able to know with confidence, both from the model and from the real world deployments already in the region, that we do see this decrease in misuse of the colonoscopy service for patients who are inappropriate. Now, there's work ongoing to really boil that down, but I think at the moment it's a little bit about getting the CCGs and the GP practices within those CCGs to switch to the pathway. And the evidence then is fairly clear from the models about the increased detection of patients with IBD and the decreased use in unnecessary referrals. I'm not sure that's the right answer or enough of an answer, but at the moment that's about as much as we have. Paul, would you like to add anything about what you guys are doing about this?
Yeah, so just exactly what you said, the overall rates will probably remain roughly the same, if not increase, but with the way that the world's going. But it's our benefits manager, Lisa Healy, she describes it as the case mix. So it's within those volumes, how do the ratios within that change? And that's exactly what we're trying to break open with the commissioning data sets from NHS Digital and what we've been testing with RightCare. So hopefully we'll be able to demonstrate that with that information, and we'll use York as the test bed for that. Once we get that information in full, we'll be able to monitor York's data over a period of time. So I think that would be a really useful exercise to do.
Yeah, great.
This data collection is very difficult. I think there's all of the evidence we have is lining up in the same direction. This pathway is one element of what's happening in primary care about patient referral practice, and it is very difficult to measure. And the model of measurement I'm not clear about. That is whether one needs to drill down in detail on a small cohort or whether you can get a broad brush picture. I think it's unclear. I can just answer one question I've got from David Evans is the size of the prize. We're estimating about 4,000 fecal calprotectin requests per million of population per year, based on what's happening in North Yorkshire. So if compliance is good, if you're getting 100,000 saving per 1,000 tested, so that's 400,000 saving per million tested, you've got a size of the prize.
Great, thanks, James. A couple of other questions that have come in about what resources do we think we would need in order to support the rollout effectively, e.g. clinical lead time, project management time. So definitely need a program manager, and I would advise getting some form of clinical leads such as James. So these can either be consultant gastroenterologists who are have a keen interest in IBD, IBS management, or even GP leads with an interest in gastroenterology. Just somebody to be able to champion that work and to be able to help you go out to the right people and have those discussions with, with colleagues on a similar level, definitely helps those conversations along. Program management, you will need quite a bit of time at the beginning to definitely go and identify the right people to go to those places to talk to them and to get an understanding of where they are. The types of people that we've found in Yorkshire and Humber varies depending on how the CCGs are set up. So some of them have been primary care leads, we've had planned care leads, we've spoken to chief nurses. The chair of a CCG has been the one that's been actively interested in developing this. So I think it's knowing who your CCGs are and kind of who the movers and shakers are within your CCGs, which I hope you kind of already know in some ways, to try and start those conversations. They may not be the people that to drive the development, but at least if you get somebody interested, they'll be able to send you on to the right person. Yeah, go on, James.
We found, haven't we, Vicky, that we're often pushing against an open door here, but I think you need generally to go to the CCGs first and find someone in whom this is usually on in their to-do box. But then there's a second order of people. Once you've got that hooked, we do generally need a primary care support, and we then need to go into secondary care, make sure there's a gastroenterologist who will give local leadership, and then also the labs are very important because the labs deliver the test and they need to be part of the process. So all those elements have to be aligned, but it is usually first a member of the CCG.
Yeah. So I think we have time for one more question before we have to wrap up, I'm afraid. So I'm just trying to pick through. Is there anything that's stuck out with you?
Vicky, one of the main questions that we get asked when we're talking to the system is around, and this is one for James really, I guess a fear of losing business from the trust, and I know, James, you explained that you could then focus on things like cancer, and is that the answer, do you think, to that kind of
absolutely.
Query?
This is exactly what it's a redirection of resource, and I genuinely don't think that this is a problem. There's every single endoscopy unit up and down the country is struggling and is offering waiting lists at additional cost. So any saving, almost every secondary care provider would want for, and it would just mean a balancing rather than a loss of income. But yes, this is ultimately about using resource widely, and that's our duty within the NHS.
Fantastic. Thank you.
And lastly, to Rachel Turnbull, frontline gastroenterology. If you Google frontline gastroenterology, you'll find the paper. Or I can send it to you if you prefer.
Thanks, James. So I think that comes to the end of this session, I'm afraid. Thank you very, very much for coming. What we're going to do is we'll capture all of the questions in the chat box that's come up, and we'll try to make sure all of them are answered, and we'll share those questions and answers around when I share the slides. So if there is anything that you think of after the WebEx, please feel free to drop me a line, and I'll be more than happy to answer. So it's just victoria.hilton@yhahsn.com, and I thank you all for joining. Thank you.
Thank you.
Thank you.